Well, good morning, everyone. We're going to go ahead and get started. Stragglers can come in as they might. It's my pleasure this morning to introduce you to Laura Banford. As many of you know, we're in the midst of a search for a permanent director for the Owen Clinic, and Dr. Bamford is one of our candidates for this position. She's going to be spending the day with us, visiting Owen Clinic and ID faculty here at the AVRC and at the Owen Clinic. But she's going to start off the day by doing a talk on some of the things that she's been working on in her current position. So Dr. Bamford is currently the director, as you can see from her title here, of Clinica Bienestar, which is a program embedded within the Philadelphia FIGHT Community Health Centers in Philadelphia. She did her medical training at Jefferson Medical College and her internship and residency at Columbia in New York, and then her fellowship and a research fellowship at the University of Pennsylvania Perelman School of Medicine. She spent 3 years as an assistant professor of medicine at Drexel University College of Medicine, and then transferred over to her current position and is also a clinical assistant professor of medicine at the University of Pennsylvania School of Medicine. So her major areas of clinical and research interest obviously have to do with HIV, or she wouldn't be here. But as a component of HIV primary care, she has implemented the MAT program, Medical Assisted Treatment for Opioid Use, in her HIV population in Philadelphia, and is going to talk to us this morning about complications of injection drug use and some of her experiences using interventions to combat the opioid epidemic in Philadelphia with her patient population. So it's my pleasure to introduce Dr. Bamford.
Thank you very much, Dr. Benson. And thank you all for inviting me to be here today and meet with many of you and present on this topic that's very important to many of the patients that I see in Philadelphia. Sorry, I hit it where? Okay, so just two disclosures. Maybe it's back here. Sorry, is it over here? Sorry. Okay. So just to start out, really what governs a lot of the work that I do is the principle of harm reduction, and it refers to the policies, programs, and practices that aim to reduce the harms associated with the use of psychoactive drugs in people who are unable or unwilling to stop using. And the defining features of harm reduction are the focus on the prevention of harm rather on the prevention of drug use itself, and the focus on people who continue to use drugs. And this, actually is the principle that Health Canada uses, not only for substance use disorder, but for all of their medical care. And, really, I think, as you'll see throughout my talk, is what has governed the policies that we've enacted at Philadelphia FIGHT. So just first, a few definitions and terms. So when we talk about injection drug use, I think it's first important to talk about the equipment that's used. And so for those of you who don't know, this is kind of everything that someone who injects drugs would use. So first, the needles and syringes. And then the cookers to help dilute the substance of use, and then water to dilute that cotton that's put into the cookers. Then when people extract the substance with the needle or syringe, it filters out any particulate matter, and then a tourniquet in order to do the venipuncture. And then modes of use. So first, there's intravenous or intraarterial use, which is called mainlining. And then people also can use in other ways, and either intentionally or when they miss a vein, can either inject subcutaneously or intradermally. That's called skin popping, or intramuscularly, which is muscle popping or muscling. And so obviously, depending on how people are using, also determines kind of where they're at risk for certain kinds of infections related to injection drug use. And so this it's kind of a synopsis of where we're at with the opioid epidemic. And this slide, the takeaway from this is really just to show that heroin use, and particularly injection drug use of heroin, has increased in every demographic group in the United States. So it really does not discriminate. It's increased amongst men and women in all age groups, in all races and ethnicities, independent of annual household income and also insurance status. And then this is kind of the toll of the opioid epidemic, and just the exponential increase in opioid related deaths in the United States. So in 2017, we saw 70,237 deaths related to drug-related overdoses. And a few things that I want to point out from this is, first, what's driving this is in that kind of turquoise blue are these synthetic opioids other than methadone, and that is fentanyl. So it's fentanyl that's really adulterated the entire supply of heroin, at least on the East Coast. And that's really what's driving this epidemic, because fentanyl is 50 to 100 times as potent as heroin. And then two other things I want to point out. So right about here, where that kind of an army green line crosses the other green line, is where heroin, and that's about 2014, where heroin surpassed the natural and semi-synthetic opioids as cause of opioid-related deaths. And that's where heroin or injection drug use surpassed like prescription opioids, so sometime around 2014. And then later on, around 2016, is where you see where the turquoise line is surpassing kind of the army green line, and that's where fentanyl surpassed heroin is really driving this epidemic. And how does that relate to other preventable deaths or other causes of mortality that affect the young people that we see? So even though these are 2015 numbers, you can see that in 2015 the deaths from opioid-related overdoses were 52,000. I already showed you that we've far surpassed that in 2017, but that compares enormously increased compared to HIV/AIDS deaths at their peak in 1995 at 43,000, and also to other preventable causes of death. So car crashes, gun deaths, and gun homicides are all far fewer than drug overdose-related deaths. And then, what do the overdose deaths look like as a nation? So you can see that most of the deaths are happening, through Appalachia up through the Northeast. And so everything in that dark blue are states that have significantly higher rates compared to the United States as a whole. You can see here in California, you're doing very well, far lower rates as a whole. So why is this? And I think if you overlay this map with a map of where opioid prescriptions are the greatest in the country, most of them are happening exactly where you see these statistically higher rates of opioid-related deaths. Okay, and so how are we doing now? So I told you the 2017 numbers. So last year in 2018, for the first time, we've actually seen a decrease in deaths. So at least some of the interventions that we're doing, education and public awareness, and some of the other interventions that I'll talk about later are starting to work. And these are still predicted numbers, but we did see a 5.1% decrease in deaths related to drug overdoses, and there are about 68,557 predicted deaths last year, and that's the first decline since 1999. And in Pennsylvania, and again, these are predicted, so once we get all of the final toxicology results, this may change, but we are at least finally seeing a reduction in Pennsylvania. There was a 6.6% increase in California, and some of that may be related to we think the adulteration of fentanyl into other substances. And I think the reason that there hasn't been, another reason besides the increase in the opioid prescriptions in certain parts of the country where we're seeing more deaths, is that on the West Coast, it hasn't been as easy to adulterate the heroin supply with fentanyl, because more of the heroin here, as I understand, is black tar heroin. So not, I guess this, chemically isn't as easy to mix it in. And so the concern, I think, in places where we're seeing increases now is not that the fentanyl is adulterating heroin, but that it's being mixed into cocaine and methamphetamine. And so we've seen increases, as I'll show, in cocaine and methamphetamine overdose deaths. And it may be because there's actually fentanyl in that supply. And that's what this graph shows. So the top line is, you can see, this is overall opioid overdoses. And you see we've plateaued in 2018 and maybe even now seeing a slight decline. But the brown line is synthetic opioids. And so even though overall opioid-related deaths have decreased, actually that black line is fentanyl. So fentanyl deaths, or at least drug-related overdoses that contain fentanyl, are still on the increase. And that is the same for that pink line, which is cocaine. So cocaine overdose deaths increasing, and also the gray line, the psychostimulants, which would be crystal meth. And again, the reason is that these substances are being adulterated with fentanyl. And so you'd ask, like, well, why is that? And the thought is that unlike opioids that people have a physical dependence to, and when you stop using, go through opioid withdrawal, the same isn't the case for cocaine and crystal meth, where yes, people have a psychological dependence, but they don't go through a true, like, as awful a physical withdrawal. And so I think the drug dealers are putting the fentanyl into the cocaine and the crystal meth, and even other things. In Philadelphia, we've seen K2, or the synthetic cannabinoid, being adulterated with fentanyl. And so people feel physically sick, in the days or two after using these substances, and don't understand why. And so go back to the substance and instantly feel better. And it's because they're treating the opioid withdrawal. Okay, so a little bit about the opioid crisis in Philadelphia. So there were 1,116 deaths attributed to drug-related overdoses in 2018. 84% of those involved opioids, and that's mostly all fentanyl. Fortunately, we have seen an 8% decline compared to 2017, so we're very optimistic about that, and that the interventions that we've put in place are working. This is a map of Philadelphia County, and each red dot represents a fatal overdose in Philadelphia County, at least in 2016. And so what you can see is that they're spread out across the county. So it's not a disease of any one zip code, but something to note is this cluster right there in the middle is Kensington, or the neighborhood where Clinica Bienestar is. So we are right in the epicenter of the opioid crisis, and that was intentional. So a little bit more about where Philadelphia ranks nationally. So of large counties in the United States, we rank third, behind Baltimore and Allegheny County in Pennsylvania, where Pittsburgh is, in age-adjusted overdose death rates. So, and now onto a little bit more specific to people living with HIV. So this was an oral abstract that was presented at CROI this year by Karen Bosch from the CDC, and this looked at HIV surveillance data, and specifically opioid overdose deaths among individuals living with HIV between 2011 and 2015. And what this showed is that the rate of all deaths, and these were crude rates, but the rate of all deaths among persons with diagnosed HIV was 12.7% less in 2015 than in 2011. So overall, people living with HIV, as you guys all know, are doing far better. But with the advent of the opioid epidemic, the opioid overdose death rate among people living with HIV was 42% greater in 2015 compared to 2011. And if you look at certain subgroups, by age, sex, race, ethnicity, transmission category, and U.S. Census region, there were increases in all of these groups, with the exception of here on the West Coast. And deaths were highest among older individuals compared to younger individuals, higher among people who identified as female compared to male, higher among whites, obviously higher amongst people who inject drugs, as opposed to using intranasally or other ways, and then highest in the Northeast compared to other parts of the country. And again, these are crude data, but the thought is like these numbers are far higher than the general population. So what is happening with people living with HIV? As we all know, folks living with HIV often tend to have more substance use disorder, often may not have access to the same medical care as people not living with HIV. And so perhaps all of these things have higher rates of comorbid mental illness. And so all of these things may be contributing to these increases in mortality, which is quite alarming. All right, so now on to just some of the medical complications of injection drug use itself. And again, a lot of these complications are dependent on how people are injecting and in some ways of injecting. So injecting subcutaneously or into a muscle is far more risky for transmission of a lot of these infections compared to intravenous injection. But as you all know, people who inject are at high risk of acquiring HIV, and also hepatitis A, B, and C. B and C, obviously, because of similar transmission to HIV, but hepatitis A, we're actually in the midst of a hepatitis A outbreak in Philadelphia right now. Mostly because of comorbid homelessness and people who are injecting, living on the streets in unsanitary conditions. So important to screen folks for hepatitis A and then vaccinate for A and B if not immune. So skin and soft tissue infections are a huge risk, both abscesses, cellulitis, and septic thrombophlebitis. Pulmonary complications, so community acquired pneumonia, pulmonary tuberculosis, mostly because people tend to hang out in close proximity to each other in sometimes in unsanitary conditions, and then sharing cigarettes, sharing crack pipes, things that transmit pneumonia and tuberculosis. Foreign body granulomatosis, because of the things that the drugs are cut with, can actually cause like granulomas anywhere in the body, but commonly in the lungs. And then septic emboli, either because of underlying endocarditis or thrombophlebitis, from right-sided endocarditis or from thrombophlebitis, and then cardiovascular risks or infective endocarditis, lymphedema, because when people inject into veins, it disrupts the valves in the veins, and then people can get lymphedema in the arms and the legs, and then thrombophlebitis, even the abscess of an infection like septic thrombophlebitis. CNS complications are epidural abscess and brain abscesses. We can see splenic abscesses, bloodstream infections, pseudoaneurysms, deep venous thromboses when the thrombophlebitis progresses. Musculoskeletal complications include psoas abscesses, septic arthritis, osteomyelitis, and tenosynovitis. And then hematologic complications, iron deficiency anemia, because people are injecting so frequently and losing a lot of blood, people actually can become iron deficient. And then one of the newer complications we're seeing is secondary or AA amyloidosis, which I've seen a few patients present with an acute kidney injury, and that's just because of the chronic inflammation from probably the chronic infections and the chronic inflammation from years of injection drug use. And then finally, high-risk behaviors that are associated with injection drug use. So individuals who inject drugs often also participate in transactional sex. So screening for STIs is really important. We've seen a huge increase in violence and assault in Philadelphia related to drug deals gone awry, and then trauma, both physical trauma, from accidents when people are under the influence of a substance, but then also the psychological trauma of years of substance use and homelessness. All right, so when we talk about all of those infections, where do the bacteria come from, and how do they get introduced into all the places that I just mentioned? So all of these infections can come from either bacteria or fungi that actually are on the surface of the skin when people inject, or in saliva. The common practice to lick a needle or even blow into the barrel of the syringe to clear out the syringe or needle before people inject, so they can introduce oral flora, where it shouldn't go. There can be bacteria or fungi in the drug itself. And then also in the diluents, so in the water that people are using to dissolve the drug, in the filters, particularly people are reusing filters. And then also, and all of these things then can get introduced into the subcutaneous tissues, into the muscles, or into the bloodstream. And people who inject drugs are 16.3 times more likely to develop invasive MRSA infections compared to the general population. They tend to be colonized more frequently with MRSA. And because of all this, hospitalizations for serious bacterial infections, including skin and soft tissues infections, infective endocarditis, epidural abscesses, and osteomyelitis have all been increasing over the last decade in the United States in people who inject drugs. All right, so skin and soft tissue infections are the most common medical complication in this population, and the top reason that this population gets hospitalized. It's estimated that between 6 and 32% of people who inject drugs have an active skin and soft tissue infection at any given time. And risk factors include female sex, and the reason is it's thought that women don't access like syringe service programs as much as men, and therefore maybe reusing syringes and needles more frequently than men. Obviously, frequent injection is obvious. Inadequate skin cleaning, subcutaneous or intramuscular injecting compared to intravenous injection. HIV infection increases the risk of skin soft tissue infections, and also needle sharing. And the organisms that we worry about most commonly, Staph aureus and Group A strep, just like the general population, but also, as I said, oral flora, because of the reasons I mentioned, Pseudomonas, which can live in the water that people are using to inject if they're not using sterile water, and then gram-negative enteric bacilli, also again that contaminate the water or the drugs themselves that people are injecting. Okay, so a little bit about, I guess you've all seen these cases perhaps, or heard of these cases, and I had presented this at grand rounds at Penn, so I thought I would leave this in here, but tetanus botulinum can also contaminate black tar heroin, and apparently when it's shipped into the United States, sometimes in like the barrels of the wheelbarrows of trucks, you can get contaminated with dirt that then contaminates the black tar heroin. And there was only one case over the last 10 years, between 2006 and 2016 in San Diego County. And then just last year, there were 9 cases of wound botulinum that were seen. And you can see the breakdown. So 9 total patients, 10 had reported black tar heroin use. 6 injected by skin popping, which, as I said, increases the risk of skin and soft tissue infections. 6 needed to be intubated, and one had died before this was recognized, and antitoxin could be administered. But it presents the same way as botulism does in general, with droopy eyelids, blurred or double vision, slurred speech, and a descending paralysis. And in a few of these cases, because of the kind of unresponsiveness of the patient, Narcan was administered first. We thought that this was an overdose before it was recognized that this was actually wound botulism. All right, so a little bit more about infectious endocarditis. So the annual incidence in the United States in this population is estimated to be somewhere between 1% with a lifetime prevalence of 12%, and compared with the general population where we mostly see strep species as the most causative organism. Staph aureus is by far the most common cause of infective endocarditis in this population, so on the order of 68% versus 28% of cases in the general population, and more often involves valves on the right side of the heart, particularly the tricuspid valve, and then streptococci and enterococci are the next most common pathogens, and less commonly we see fungi and gram-negative bacilli. But again, we're going to see kind of stranger organisms in this population because of the practices and because of the risks from the water supplies that are being used and whatever bacteria or fungi are contaminating the drugs samples. And people who inject drugs have higher rates of reinfection, likely because of ongoing use and damage that's already been caused to the valve, and also valve-related complications, often because goes unrecognized, or people present really late to care. We've had a huge problem in Philadelphia with getting people to stay in the hospital to get the care they need, trying to give people medications to prevent withdrawal while people are in the hospital so that they're not feeling worse in the days after they've been there compared to when they come in the first time. So often goes untreated or unrecognized for longer in this population, and therefore people have more complications. So this comes from the HIV surveillance network from the CDC, and this was a study in 20 cities in the United States who looked at HIV infection and HIV-associated behaviors among persons who inject drugs in 2015. And alarmingly, 27% of the HIV-negative respondents reported receptive sharing of syringes in the previous 12 months. And receptive sharing was higher amongst whites compared to Latinos and Blacks. And I think this speaks to why we need to do far more education, but I think this population didn't understand that not only sharing syringes, but sharing all injection equipment is a means for transmitting HIV and hepatitis C. And so 49%, a higher number reported sharing other injection equipment, and with the similar patterns, greater numbers of whites compared to Latinos and Blacks sharing any injection equipment. And unfortunately, only about half of this population receives syringes from a syringe service program, and only a little over half, despite their high-risk behaviors, was accessing HIV screening during this time period. So these are so the HIV incidence in the United States. And yes, we have one. Yeah, I'm going to talk about it a little bit later. But I can, if I can answer something now, or I can talk about it. No? Okay. Yes. So this is just to point out kind of the HIV incidence among people who inject drugs over time. From 1992, when just under 25% of individuals that year reported injection drug use as their HIV acquisition risk factor. And we've made great strides. And this is one of, I think, the hugest public health successes, through syringe service programs and education and public awareness, and all the way down, if we take this line all the way out to 2016, down to 9% of new infections. And this includes 6% who identified injection drug use as their risk factor, and another 3% who identify both MSM and injection drug use as their risk factor. And so we've made tremendous progress until now. We've seen a few outbreaks, and I guess I'm sure know about the Scott County, Indiana story, but this was a county in Indiana with the lowest life expectancy in the state, high unemployment rates, high poverty rates, low high school graduation rates, but despite all that, in 2014, had no known HIV cases, living in that county, until, as of April 1st, 2018, 225 new infections. And this is kind kind of, multifactorial reasons. Like I think one, all the things I mentioned, really like all this very low health literacy, but also this was a time when then Governor Mike Pence defunded Planned Parenthood in the state, and the only HIV testing site in this county was Planned Parenthood. So people had no place to go to access HIV testing. And at the same time, a prescription opioid called Opana came on the market, and the pharmaceutical company that made Opana, tried to, they essentially was made with a tablet with a latex capsule, and the idea was to deter use, so deter it from being crushed up and used intranasally. But despite the low health literacy, this population figured out that if you cooked it, if you diluted it with water, the capsule would float away and then it could be injected. There was, obviously people did not realize that sharing, syringes, injection equipment could transmit HIV. There's this very poignant piece on NPR about a nurse from this county who knew that she shouldn't share. She was, actually, became addicted to opioids and knew that she shouldn't share syringes, but didn't know that using the same cooker we could also transmit HIV. And there were a few houses in this county where people would go, and everyone using the same huge cooker. And there was a kind of sophisticated phylogenetic analysis done that all those 225 people actually had the same strain of HIV, so all transmitted, from the same network. Okay. And then on to Philadelphia, where we're also seeing an HIV outbreak. So in yellow, the HIV epidemic in Philadelphia in the early days was largely driven by injection drug use. And you can see in 1992 in yellow that half of all infections in Philadelphia were attributed to injection drug use. And that is the same year that our syringe exchange opened, Prevention Point Philadelphia, which I'll talk about more. And you can see that over time, now all the way out here to 2016, through the efforts of Prevention Point Philadelphia, there are only 33 new infections, and down to 5.2% of new infections that were attributed to injection drug use. So again, a really great public health outcome. But now we've seen, and over the last 2 years, are seeing a huge increase in new infections. So I told you, out to 2016 were the lowest numbers of new infections overall, amongst all risk groups, down to 33 amongst injection drug users. And then over the last 2 years, through the end of 2018, we've seen a 115% increase in new infections in this population in Philadelphia. And then now this year in 2019, we've had 43 new infections as of June. So the concern is that we're going to see even worse numbers. So we're bracing ourselves, and I'm going to talk about all the things that we're putting in place to try to curb this epidemic. So in addition to increases in HIV in some populations, and I think not only Philadelphia and Indiana, but I think Lowell, Massachusetts, and Boston, Massachusetts, and Seattle, Washington, there are other pockets in this country that have also seen, similar small numbers, thank goodness, but still alarming increases in new infections. We've seen the same with hepatitis C. So between 2004 and 2014, we saw a 400% increase in new hepatitis C infections in young people between 18 and 29, and that's the top orange line. And then, the thought is that this is related to injection drug use, and where there's no direct epidemiological link, you can see that as the hepatitis C infections are increasing, so are admissions to inpatient facilities for opioid use disorder. So there's this ecological relationship. They're increasing together, and therefore thought that the opioid epidemic is causative of this new hepatitis C epidemic. And the same thing on a slightly smaller scale, but the same increases in numbers are happening in individuals aged 30 to 39. So It's estimated that about 2.5 million people are living with hepatitis C in the US, and these are people who are viremic with hep C RNA. And 40% of people who inject drugs with recent injection drug use are known to have hepatitis. It's thought that within the first 3 years of injecting that 40% of people will acquire hepatitis C, and 80% of new infections in 2014 occurred among people who inject drugs. And this is the hepatitis C care continuum. So even though it's estimated that 2.5 million people are living with hepatitis C, only about 36% are aware. And we're doing far worse than, if we were to put the HIV care continuum up here, doing far worse with hepatitis C. And then of that 2.5 million, only about 11% have actually been treated. Although those that have been treated, 95% have been cured. So despite having great medications to treat hepatitis C for sustained virologic response, the medicines aren't reaching the people who really need them. Okay, so what can we all do to combat the new HIV outbreaks, hepatitis C outbreaks, and other complications of injection drug use? And I'll talk a little bit about what we've done in Philadelphia, and particularly at the Clinica Bienestar, where I am the medical director. So I think the first thing we can do is change the language that we're using related to addiction. And so this is the Addictionary, and I think there's a lot of stigma, obviously, related to substance use, and bias, on the part of medical providers. And until we can change that, patients aren't going to feel comfortable disclosing their use and coming to us when they've started using again after periods of not using. And so some of the first things we can do are use person-first language. So rather than calling someone an addict or a user, abuser, junkie, say say this is an individual who suffers from addiction or suffers from an opioid use disorder, a substance use disorder, an alcohol use disorder. Also, calling people clean, when they've been, not used for a period of time, that implies that they were dirty beforehand. And so instead, say that people have started using again or relapse, in the same way that we do with any other chronic disease. And then also referring to test results, particularly urine drug screens, not as clean or dirty, but as positive or negative, or as expected or not as expected, as we do with any other medical tests that we perform. All right. And then, in addition to changing the language, around substance use disorder, also thinking about substance use disorder as a chronic disease. It's not a character flaw or a moral defect, but it's a chronic brain disease that relapses and remits, just like many other chronic diseases, diabetes, hypertension, and asthma. And as you can see, relapses with the same frequency as many other chronic diseases. And also adherence or non-adherence to medications is the same across all of these chronic diseases. And so I think until we, and I think it's important as as healthcare providers to start changing the language. It's the only way we're going to change the worldview about this and get people into the care that they need. Okay, so what else can we do? So some preventive care for people who inject drugs. So obviously we should be screening these individuals for HIV, hepatitis A, B, and C for the reasons that I mentioned previously. Vaccinate those that are not immune for hepatitis A and B, and also for tetanus. Counsel about the risks associated with sharing injection equipment. Educate about safer injection practices. Teach opioid overdose prevention and prescribe naloxone. Provide access to sterile needles and syringes, distribute condoms and screen for sexually transmitted infections, prescribe medication-assisted treatment like buprenorphine and long-acting injectable naltrexone, prescribe PrEP for HIV prevention in this population, provide access to supervised injection facilities, and then educate about early signs of infection related to injection drug use. So sometimes a fever can be the only manifestation of endocarditis. So, educate this population to present to us as soon as a fever starts or as soon as their skin becomes red or warm. All right, so I'm going to break down some of these things now that we've talked about. And so one is, treating HIV in this population, obviously figuring out and delivering it in kind of more novel ways is obviously, as I mentioned, a lot of these folks are homeless, have a lot of other competing subsistence needs. So really trying to be creative about how we can get these patients medication, whether it's daily directly observed therapy or weekly or the way we dispense it in pill packs, or I got these little aluminum pill containers that people can wear around their necks that fit a week of their antiretrovirals in them, and we have them in their watertight and have them come back every week, because we know that HIV treatment has dramatically increased quality of life expectancy in people living with HIV. Went from life expectancy of 35 to almost that, approaching that of the general population in the U.S. So very important to get this, life-sustaining medication to these patients. We know that HIV viral suppression prevents sexual transmission of HIV to uninfected partners. And it's unknown, but also very likely reduces transmission via sharing syringes and other drug injecting equipment. We should consider, in all populations, but particularly in this population, the rapid or immediate initiation of ART. And there's good data to support this in other parts of the world. So in a randomized controlled trial in South Africa, participants that are randomized to same-day ART. So rapid would be same day, and immediate is within a week of HIV diagnosis. So those that were randomized to same day were significantly more likely to be virally suppressed at 10 months. And so just, in South Africa, first they excluded the possibility of tuberculosis or cryptococcus meningoencephalitis, because obviously in those two instances you'd want to delay therapy. But when those were excluded, they were able to initiate. In a similar study in Haiti, same-day initiation resulted in significantly increased retention and care and viral suppression at 12 months. And then there was a pilot study in San Francisco in 39 individuals that suggested that initiating ART in the same day of diagnosis. So again, a rapid start might modestly shorten the time to achieving viral suppression. And so obviously there's huge benefit to the individual for starting early, but also huge benefit to the community and decreasing the community viral load as quickly as possible to prevent further new infections. All right, so this is the clinic in the epicenter in Philadelphia of the opioid epidemic, HIV epidemic. It also has the highest rates of HIV and hepatitis C in this zip code in Philadelphia. And we started this like 6 years ago now with a SPINS grant, so some grant funding from this called Special Projects of National Significance. And the idea was to target a very vulnerable population, Latino population living with HIV. And so we decided to target individuals of Puerto Rican descent who are living with HIV and weren't currently engaged in HIV care. It just so happens that individuals of Puerto Rican descent have some of the highest rates of HIV acquisition via injection drug use. And if you're born on the island of Puerto Rico, you have like a 20% increase risk of sharing injection equipment and therefore acquiring HIV. And this was a collaboration between Philadelphia Fight Community Health Centers and Prevention Point Philadelphia. So this is the syringe service program in Philadelphia. And so we literally took the clinic from Center City, Philadelphia to Prevention Point and collaborate with them, to the epicenter of the epidemic. Because even though they're 5 miles apart, we knew because of all the barriers that our patients face that they would never make that trip. And so we like to say we took the clinic to them to try to decrease as many barriers as possible. So what were some of our strategies to engage folks in HIV care? So one, this clinic was built on decades of Prevention Point's trust in the community in North Philadelphia and their expertise in harm reduction strategies. And we combined that with decades of Philadelphia's fight expertise in providing high quality HIV in hepatitis C care. And so, I recognize that maybe this isn't generalizable to all parts of the United States, but what I think is generalizable about that is when we look at the HIV care continuum, we still have about 50% of people who are not virologically suppressed in the US. And so when we think about some of the most marginalized populations, I think having these collaborations and thinking about ways to engage these folks, either going into mental health programs or substance use disorder programs, or wherever people are hanging out, wherever they go, which might not be the HIV clinic, but then to partner with that organization to try to reach these most vulnerable people. So again, we located the clinic in the epicenter of these co-occurring epidemics in Philadelphia, and we've co-located most all of what we could think that people would need, so that people don't need to prioritize one life-sustaining intervention over another. So we've co-located medical services, so HIV care, hepatitis C care, medication-assisted treatment, social services, medical case management services, and then harm reduction services, including the syringe exchange services. We have very flexible appointment scheduling. So for people who can keep appointments, great, we give them appointments. But for those that can't, we allow people to walk in anytime, either for follow-up visits or for new patient visits. We recognize that a lot of our patients don't know what day of the week it is, let alone what time of day it is. And then we also offer medication delivery. So we pair up with a pharmacy that delivers medications directly to prevention points. People don't have to have that extra step of going to the pharmacy to pick up their meds. And we can offer them daily or weekly DOT, depending. Again, we really try to meet people where they're at. So really try to tailor the services to each individual patient's needs. All right, and then this is some of our data. So this was a year after enrollment. And just a few things to point out is that our viral suppression rates at a year were 83%, which we're very proud of. And compared to Ryan White funded clinics as a whole in the US, it's about 86%. So I think probably not statistically significantly different. And that compares to rates in Philadelphia from 2016, which were only 50%. So we're very proud that we were doing better than the rates in Philadelphia as a whole. And then the other thing to point out is that our retention rates, so our retention rates are actually higher than our viral suppression rates, which we don't, which I think when you look at the HIV care continuum in the US, it is often the opposite, that actually the viral suppression rates are higher than the retention, and mostly because people who are doing very well, even though they're supposed to come and see us twice a year at a minimum, don't. We see them once a year, even though they're taking their meds the whole year. But what we see is that our patients are coming in even though they may not be taking their meds. And what we see that is a lot of opportunities to engage and help them with everything else that's going on in their lives. Do you have a question?
Yeah. So to be at Clinica Bienestar, do you have to be a substance user?
Yeah. So right. So
or engage in substance use disorder?
Yeah, for the study, the inclusion criteria for the study, or you had to be of Puerto Rican descent, have a history of injection drug use, and living with HIV, and then not engaged in care or newly diagnosed. But we decided at the beginning that because there were so many other people in that community who needed, we've seen everyone. So the clinic now is expanded to about 160, maybe 50 of those are of Puerto Rican descent. So we really are seeing everybody.
Is it known to be a place where, people have substance use disorder and are thus it's more stigmatized? People don't want to have, what's been the experience related to stigma? And yeah.
I think because of, again, the Prevention Point's been around since 1992 and has this tremendous trust. It's really a sanctuary for people. They have a drop-in where people can come and just hang out, get out of the element, get off the streets in January in Philadelphia and hang out. They have warm lunches twice a week. People get their mail delivered there. So it's really a safe haven for a lot of people. Yeah.
What is your time point to viral suppression?
This is a year.
It was 1 year.
1 year. And then a little bit about the patient characteristics. So the average age was 43, 81% identified as male. And then a lot of barriers to accessing healthcare. So 40% reported being homeless in the previous month, 44% reported going hungry in the previous week, 51% reported feeling very depressed in the previous week, and 15% of our participants were incarcerated in any given month. And 89% were out of care at the time. And we defined that as not being out of care for any 6-month period in the previous 2 years, and only 11% were newly diagnosed. Although, as I've shown you, the newly diagnosed is actually increasing. We're seeing more new diagnoses over the last few months than seeing people who were not previously engaged. Okay, so a little bit about hepatitis C treatment, and I think providers have been, some providers in the US have been reluctant to treat this population. They think people think that because of ongoing substance use that people can't adhere to hepatitis C medication treatment or will get reinfected, and the evidence has not shown that. So in clinical trials among people injecting drugs who are reporting current injection drug use at the start of treatment and or continued use throughout treatment, still had 95% SVR rates. And in a small study in New York, a cohort study of 89 patients in a primary care clinic there, they found greater than 95% SVR rates, regardless of active substance use. So some real-world data, other than the clinical trials. All right, and then the mathematical modeling suggests that modest increases in treatment with SVR could reduce ongoing transmission and achieve substantial reduction in hepatitis C prevalence. So this really requires increasing efforts along the entire hepatitis C cascade, obviously increasing screening and linkage to care and offering folks direct-acting antiviral treatment. And when those numbers that I showed you at those great SVR rates, people do even better when hepatitis C treatment is paired with other preventive services, so safer injection education, syringe service programs, and offering folks medication-assisted treatment. And then the other concern that folks who are actively injecting will just get reinfected has not been borne out either. And so this is a global meta-analysis, and we'll just focus on the United States. So you can see that reinfection rates are somewhere between 9 and 15 per 1,000 person years of follow-up. But that compared to the rate of incident Hep C infection is somewhere between 60.1 and 272. So, yes, people are getting reinfected, but nowhere near the rates of incident infection. And this is, as I mentioned earlier, this is the population, where numbers are increasing. And so until we treat this population, we're not going to impact on incidence and prevalence. All right, so some safer injection techniques. And this comes from a manual called Getting Off Right that's published by the Harm Reduction Coalition. And it's a collaboration between consumers and also service providers. And so it's great. I refer to this a lot for patients, but we should teach patients to wash hands, clean the area to be injected with alcohol swab, never share any kinds of injection equipment, always inject toward the heart at a 15 to 35 degree angle. Veins in the arms are preferred over the legs, and that's really to reduce lymphedema, because the valves in the legs are more important. When they're disruptive, then people get more lymphedema in the legs. Use different arms and different veins, to reduce risk of infection and thrombophlebitis. Use sterile or boiled water. Tap water, bottled water is not sterile, and so people can access sterile water at harm reduction service centers, or boil water for 10 minutes. Prepare your own clean area for use away from others, because even blood on the surface of a table or area, can transmit hepatitis C and HIV to another individual. And never reuse needles. You can see this is a needle under a microscope. So before use, and then even after one use, you can see how kind of barbed and disrupted the tip gets. And then after 6 uses, and so you've taken a very small bore needle and make it into an even larger bore needle, and you see how over time that can increase transmission of HIV, hepatitis C, and even serious bacterial infections. All right, so we should refer folks to syringe service programs. They are known to reduce rates of HIV, hepatitis C, and high-risk injecting behavior. without increasing drug use, without increasing the number of people who inject drugs, or needles that are discarded in an unsafe manner in the community. And for parts of the country that don't have access to syringe service programs, medical providers in the District of Columbia and all 50 states except Delaware and Kansas can legally prescribe syringes to patients, and pharmacies can legally dispense them. And all you need to write as the diagnosis is HIV prevention or hepatitis C prevention. And this is a website from Temple Law School that actually talks about the specific laws per state related to this. And then this is a map of the United States where all the syringe service programs are. So you can see in light blue, the vast majority of the U.S. has 0, to 2 states, including Pennsylvania. So we only have 2 syringe service programs in all of Pennsylvania, 1 in Philadelphia and 1 in Pittsburgh. You guys have the highest number here in California of 43, although I hear that only 2 are quite large. What? Yeah. When in San Diego. Okay. So yeah. So all right. So limited access. So we all have more to do, but they can be prescribed too, and they can be prescribed, or in a lot of states, patients can purchase them in pharmacies. All right, and then this is what's available at syringe service programs. So sterile syringes, sterile water, sterile cookers, alcohol swabs, tourniquets. All right, and this is Prevention Point, you asked about before. So it's founded by ACT UP in Philadelphia in 1991 in response to the growing HIV epidemic there at the time. I showed you that 50% of all HIV infections were attributed to injection drug use at the time. And then Mayor Ed Rendell issued an executive order that authorized the legal distribution of syringes and established a citywide institution to manage the program. And to this day, it's only legal in Philadelphia and Pittsburgh because of these executive orders and not in the rest of Pennsylvania. And their mission is to reduce the harm associated with substance use and sex industry work. And here's, this is the location in North Philadelphia where Clinica Bienestar is also. It's in an old Methodist church there. All right, so what else we can do? We should be prescribing PrEP to this population. And the CDC recommends PrEP, daily continuous PrEP. So for now with tenofovir, with TDF and FTC, for individuals who inject drugs, who meet these criteria. So they're adult or adolescent person without acute or established HIV, and anyone who's injected once in the last 6 months, plus either reports sharing injection or drug preparation equipment in the past 6 months, or meets the criteria for high-risk sexual acquisition. So what do we know about PrEP and PWID? So this was a study, the Bangkok tenofovir study, which remains the only clinical trial we have looking at PrEP in this population. But in this study, and then they actually used tenofovir alone, not TDF and FTC, but tenofovir reduced the risk of HIV acquisition in this population by 49%. And then in subgroup analyses, and they actually did, they checked tenofovir blood levels. So in individuals that had adequate blood levels, they actually saw a 74% decline in new HIV infections in this population. But like I said, it just really hasn't rolled out on large scale here or elsewhere in the world. And a study from Baltimore showed that 25% of PrEP eligible PWID in Baltimore had previously heard of it. Only 20% had even heard of it, and 63% though said they were interested. But of all of these, I think there were 265 people who were surveyed in this study. 2 were currently taking PrEP. And so there's been a number of studies about what are the barriers, and really they're the same barriers that my population faces in taking HIV medications. And I've showed you that with the right resources, this population can take antiretrovirals. So they can take antiretroviral, they can take TDF and FTC. So some of the barriers have been low PrEP knowledge, low perceived HIV risk, past negative experiences with healthcare providers, and stigma, concerns about side effects, competing health priorities, homelessness, recurrent incarceration, and HIV-related stigma. The thought of someone binds their prescription for TDF, FTC, that someone will think that they're living with HIV and not taking it for prevention. We should be prescribing naloxone to everyone who has any use of opioids at all or a past history of opioid use. And what I've done in our clinic is I pair their naloxone prescription with their antiretroviral prescription. So each month they get their antiretrovirals and they get a box of naloxone to have. And I just say, we live in Philadelphia, we should all carry it. I carry it, you never know, because it can be stigmatizing too. But I just say, you may help somebody on the subway. We should increase access to medication-assisted treatment. So like I said, we prescribe buprenorphine and long-acting, both oral naltrexone and long-acting injectable naltrexone at Clinica Bienestar, really as an add-on. It's just part of their regular medical care. And we actually had great success in pairing those prescriptions with their antiretroviral prescriptions or their hepatitis C prescriptions in like 7-day increments. And so that's actually also increased adherence to both MAT and to Hep C and HIV treatment. We know that these modalities significantly reduce opioid use, increase treatment retention, and decrease overall mortality in this population. And HIV and hepatitis C incidence are significantly reduced when individuals participate in methadone maintenance programs. And according to a 2015 analysis based on data from the National Survey of Drug Use and Health, though only 20% of people who actually need these meds are getting them. And we've seen increases in individuals who are able to prescribe buprenorphine with the X waiver, but this 20% hasn't changed. So we have more people who need the medication. Even though we have more prescribers, we have more people who need it, and we're really stuck at this 20% level of people who need it but aren't getting it. And then we've incorporated using rapid fentanyl test strips into our clinical practice. So the composite, this is a point of care rapid urine drug screens. The composite ones actually don't currently test for fentanyl. So the opioid that's on, the opioid that's on the composite only tests for heroin, morphine, codeine. And so we've added these extra test strips. They're not yet FDA approved for use. So we're using them off label, but I also think we use a lot of things off label, and in the spirit of harm reduction, if we weren't using those, I think we'd miss that someone was actually using opioids, because a lot of, I told you that most of the heroin sample in Philadelphia is adulterated with fentanyl. Sometimes it's even hard to find any heroin. So people come in with this no opioids, we would have thought no opioids, and we may feel complacent about starting them on buprenorphine or long-acting injectable naltrexone or getting them the proper services until we started testing for fentanyl. So one, it helped us in that regard, but also to educate folks who might just report using cocaine or crystal meth, to say that cocaine or crystal meth you're using is adulterated with fentanyl, and help do harm reduction education with them and prescribe naloxone to those individuals. So again, I said that the fentanyl has been found contaminating all of these substances, even pressed into prescription pills that are sold on the street in Philadelphia, sold as oxycodone, which is really just pressed fentanyl into pills. And people who are using these drugs may be aware that fentanyl is contaminating their sample. A lot of my patients have told me, oh, but I can tell by its smell or taste or color or word of mouth. None of those have been shown to be effective strategies, and really having people test either their urine or the drug sample itself is best. So the rapid fentanyl strips are single-use immunoassay tests, and they're qualitatively detect fentanyl and its metabolite, norfentanyl. As I said, they're only licensed currently for forensic use. We're using them in urine samples, but there are some harm reduction service centers across the country who've been distributing them for folks to actually trust the drug sample themselves, which is clearly also not licensed, but they've demonstrated 96 to 100% sensitivity and 90 to 90% specificity in detecting fentanyl in some illicit drug samples. And the test strips were compared to gas chromatography, mass spectrometry. Sorry. Yes.
Are you sorry? Are you systematically collecting data on your experience using these test strips and their patient histories,
No.
and have you reported it, or can you report it?
Yeah, not yet. No, we definitely should. No, that's something we could definitely do. Thank you. Anecdotally, they're all, everyone who, I can tell you anecdotally that everyone who reports injecting what they think is heroin, all of those, it's 100% positivity. And so last but not least is, we should be offering supervised injection facilities to patients. And these provide individuals with substance use disorders a medically monitored and legally sanctioned environment to more safely engage in injection drug use. And really, I think about SIFs as medical care. They're part of a menu of medical services that should be provided to this population. And they're really designed to keep people alive. I've told you about the exorbitant numbers of overdose deaths that we're seeing, to keep people alive long enough to allow them to engage in treatment for substance use disorder. And other things that, barriers that prevent them, either they're personally not ready, or they lack insurance, or lack awareness of treatment options that SIFs provide. Access to all of that, but also a place to safely inject so that they don't overdose before they can access the care they need. This is a picture of Kensington Avenue, where Prevention Point is located. And so and you see there's this open air heroin use. And so where these are directly supervised facility, it's a community that's openly injecting. And every day when I'm at Prevention Point, there's like 5 or 6 overdoses right around the vicinity of the building. And so we're really acting as, a supervised injection facility already. And the staff there really handle the overdoses themselves. Most are not medically trained. They're case managers, and they'll call me if someone needs CPR or is having a seizure, or it's a more complicated overdose, but they're really handling this themselves already. So the first SIF started operating in Bern, Switzerland in 1986, and it was in response to increasing HIV infections and drug-related overdoses then, that long ago. And there are now 100 legally sanctioned SIFs in 10 countries and 66 cities across the world. No legally sanctioned facility exists in the US, so there's rumored to be several kind of underground facilities. In Philadelphia, there's an evidentiary hearing at the end of this month where we're trying to open a SIF there called Safe House. And fortunately, the judge, in this case, we're being sued by the Department of Justice, and the judge did not allow them to have an injunction against us, but the judge is at least keeping an open mind to allow us to testify, to make a decision eventually if we will open the first site there or not. Okay. So I'm sorry, I'm going over time. Am I okay still, or so like a few more slides? Okay, yeah, okay. So just to say in closing that SIFs are really, again, they're part of a menu of medical services, and when people access SIFs, they can access a lot of other medical care, and it's a very marginalized population that may not have access to any of this. And this may be their entry or gateway to so many other services like vaccinations and HIV screening and hepatitis C screening and primary care. And studies have shown that actually folks that access these facilities do have greater access to all of those other services worldwide. Thank you.